Okay, why don't we go ahead and start with the, let's ask if anyone has any questions or any challenges or questions that we can answer for you regarding how you are, any questions you have about disparity data and how we are relating it to historical context.
I think it's great to have disparity data in all of our public health or health sciences classes, especially nursing, to make sure that people understand what the deterrents are to individuals trying to seek, positive health outcomes or seek health care or make a difference in their communities, because, we're not all from the same community, so we don't understand that. And I think I try and stress that, as you do, Elizabeth and Guy, from our backgrounds with our students in nursing, to say, here's what history has done, here's how history has moved forward, but there's still much more to be done as far as decreasing disparities and making sure that, these, whether it's a myth about vaccines or it's a misunderstanding about diseases, or it's a bias towards people of different cultures that we present as healthcare providers. It's really essential that we know this, especially our students as young adults entering the working and caring world.
Thank you, Kathy. Does anybody have a different perspective than what we've presented? Do you think, a question might be, do you think it's that it's necessary to look at the historical context? If you disagree with us, that's fine as well.
I think Michelle has a comment to make. Michelle, do you want to go ahead?
Yes, I have an answer. Well, seeing that definitely, Doctor, that the disparities, as you all say, I'm just a student and this is new to me. So as you all say, that this disparity data is important to use it to be able, but then what is being done? Because you're still having victims all over because of these prejudice and all the other things that was talked about. So what is to be done to solve that problem? Thank you.
That's a great question, and it's the $6 million question. There used to be a show called the $6 million or $69 million question or something, or $69,000. But whatever the amount is, it's one of the problems that we're trying to show is that the way we are tackling disparities has had some effect for all populations in terms of improvement, but the gaps between the dominant group, which is the white population, and other populations, that gap is still as big as ever. And it's even worse in some cases, especially when we're talking about maternal and infant mortality rates. And right now, the rates we're seeing with COVID, if we just move it to today's problem. So there are many good efforts being made to address those determinants of health. And how do we tackle, the health community is, I think collectively now, it's been in drips and drabs over time, trying to address those social determinants of health, or recognize, for example, that housing is a determinant of health, where someone lives, environment is and has an impact on health. So it's not just a matter of fixing the ailment you come into your doctor for. It's what are the issues that are contributing to it that are not in your own body, right? Or maybe in your body. So our proposal is to be, especially for those of us who are now, we're in the academic world, and you're coming to the university or wherever you are, whatever you're pursuing, you're coming to school to get below the surface of an issue. And so our premise is that it's very important, no matter what you're studying, and as Catherine's a biochemistry major, and she pointed out some things that she thinks about in the context of data in her studies, in healthcare, I think in nursing, it's not sufficient to just say disparities exist. We need to truly understand what the genesis of those disparities are. What is the genesis of mass incarceration of Black males, the disproportionate number, and now women as well? What has contributed to that historically? Because unless we can change that attitude or address that attitude, we aren't going to be able to just all of a sudden say, let's change these numbers around, right? So there's mistrust on both sides of the population. And so your point is very well taken, because that is one of our part of our mission here, our vision, is that we believe that the educated student or teacher needs to promote a much greater in-depth look at the genesis of problems to be able to identify a way to tackle the problem. Right? And so open discussion is one of the key, listening to each other is a very important piece of addressing disparities. There's not a quick Band-Aid to put on this. There is no real quick fix to this problem. Thank you.
I really like in the comments what Noreen said about it's easy to blame those who suffer from diseases or conditions in underserved communities. The historical context gives us a view of a systemic cause of disease that may help us to stop victim blaming and motivate us to create opportunities for change. And I really wanted to kind of highlight that because I thought it was a really great statement, and say that one of the things that I think thinking about the historical context can help us to do is to move past kind of the surface level issues. So if we're finding that asthma, it makes the African American community more susceptible to COVID, the solution isn't inhalers or treating or recognizing asthma. While that might be important, the solution is identifying why is this group more susceptible to asthma. And there's a lot of research that shows that due to housing policies, there's suboptimal housing that's also exposed to higher levels of pollution that in the United States, African American individuals are likely to live in. And so the issue, looking at it through a historical context, helps us to go deeper and really actually address the fundamental problems that were created by these events or patterns in the past and create better health for people.
That's a good point, Guy. One of the examples I can point to quite readily is my work in Chester, Pennsylvania, which is also where I grew up. It's a working class, wasn't an industrial city. And in the years of economic downturn, the city had just about contracted with 3 major high polluting incinerator contracts that had very poor pollution controls on them. And it took the community to come out and fight that, to stop those contracts from going forward. Chester, Pennsylvania is a predominantly African American community, and we see this across the country where you have an environmental injustice taking place, where communities of color, communities of persons that are highly vulnerable, tend to be the communities where we place waste plants, polluting chemical companies, and other types of oil refineries. And we know that in those communities are some of our most vulnerable populations. And so we have to ask, why do you pursue putting those types of environmental pollutants in communities of color and communities that are in a lower socioeconomic grouping? And the same is true with the American Indian populations as well, in terms of what is being done near their tribal lands as well. Somebody, is this another chat? Catherine, do you want to tackle that one?
Oh, I was just answering Yolanda's
Oh,
question. She was mentioning the Healthy People 2030 statements that we brought up earlier. So I just put in our chat just the statements that we use and how they were in line with our presentation. But Yolanda, if you have other questions about that, feel free to let us know.
Is Yolanda there? Do you want to talk, Yolanda?
Oh, I was just asking about it because my nursing class had posted about the Healthy People 2030 initiative. So I was just wondering if you guys would speak a little more on that, because I believe that like their goals are very important. While I was reading through their website, I didn't get to go in depth a lot, but I did see a lot of like things that they're striving for that I thought was pretty important.
Thank you. That's a very good question. So Healthy People 2030 is it's the fifth, I think it's the fifth iteration of Healthy People, if I'm not mistaken. I might be wrong on that number. So, we went from Healthy People 2000, 2010, Healthy People 2020 in different stages, whereas addressing health disparities and equity in healthcare. So I have to say, when I first came out of nursing school many years ago, people were actually debating if inequities and disparities actually existed. And then we spent years where the major researchers and epidemiologists and specialists and academicians very quickly were able to put together examples of research studies time and time again demonstrating the inequities in healthcare delivery, the inequities in healthcare access, and trying to look at what were the root causes of those disparities. So now Healthy People 2030 is our current version. It just started, right? Because Healthy People 2020 ended in 2020. And so this is building upon those concepts from Healthy People 2000, 2010, 2020, 2030. So when you look at Healthy People 2030, they put some very interesting goals and objectives, first looking at their vision that we posted in that initial slide, and then one of their overarching goals. And so when you're looking at Healthy People 2030, you'll actually be able to pick out specific conditions or problems, and what are we targeting to achieve within the next 10 years. So that's how you're going to approach Healthy People 2030. Now, as I said, when you look at the data from Healthy People, when you look at the data from Healthy People 2020, you would see that the disparities or the health outcomes improved for every population in different categories. However, the gap between white and African American, American Indian, Alaska Native, Asian, Hispanic populations, the gaps have never closed. They're still as wide as they've improved a little bit, but not in proportion to the effort that's been made. So something tells us then, to me, what it tells me as a researcher and tells me as a health practitioner, it tells me that we need to have a new strategy how we're going to approach the problem. And so what we as a group are saying is we need to go back further than looking at the determinants of health to truly understand and take it in to think about how do we go all the way back to what caused the level of mistrust we're seeing between populations and the healthcare system, or the populations and the government. Where can we put that? How can we communicate and understand that mistrust? Right. It's easier for us to think, we can just say slavery. That was really a long, long time ago. Like, just get over it, right? Without thinking about what that has done to the person that is a member of a population who actually has the slave papers of their ancestors in hand, and to just think about what that means to that person. Think about the person who's a descendant of someone who was in that Tuskegee study where they were purposely not treated for syphilis, even though there was a cure found, and they were allowed to go through and die from syphilis and suffer the ramifications of syphilis. What does that do to their descendants? And then what does that do to the community that they're members of? So the goals in Healthy People 2030 are very, very well thought out and very attentive. And then it's our job to try and really critically analyze what interventions we can devise. But it doesn't help us to just create interventions that never tackle the foundation of the problem. And it tells me after all my years working that we're missing a point someplace in time here.
I just have a quick comment. I think that I'm not trying to push back at all, but I think it's a lot easier said than done, especially when the percentage of healthcare professionals who are Black and Hispanic and Native American is so little. And I think that it's only like 7% of students enrolled in medical school right now are Black or African American or Hispanic. So I think that it's an issue also of education and having opportunities to bring people of color into the healthcare field. And I think that that would help to solve or at least work towards limiting the disparities that are seen.
Yeah, I definitely don't actually see that as pushing back. I think that you're kind of creating a valuable, like, additional thing that we need to be recognizing and focusing on, which is that a lot of these groups that we're talking about are not brought to the table fully in a lot of different ways, including being part of the healthcare profession. And so, that is a really important thing that we need to do, and also prepare all providers to develop, to provide respectful care that is acknowledging of all of these different historical contexts. It is 1:56 and we're actually over time. So we really, would love to continue this conversation. Our email addresses were posted previously, and we would love to hear from any of you who have further questions, concerns, or if you'd like some of the resources that we discussed here. We have readings, we have books, we have journal articles, websites that go more in depth into everything that we've discussed here.
Could I just answer it, Claire, just quickly, Guy?
Yeah, I just
Claire,
have to go. Sorry.
Yeah. So thank you, Guy. You're wonderful. You did a great job. Thank you for being my partner in this, partner in crime. Claire, I'll just answer your question briefly. I would just say it's something that we've been preaching for years. Since I probably started teaching well over 30 years ago, it has been something that I've been preaching for years. And I put up a slide in my class every year to show here's the data on the population, and here's what our health professionals look like and are not representative. So it doesn't negate the responsibility of those of us who are in the system to be the educators and to challenge ourselves to look in greater depth through history, through studying other courses, through reading. I can't emphasize reading enough. Participating in community action groups, get into the communities we're working with and try to and be partners with those communities and engage and listen. We often go in and think we are the educators, and what we are the students in working with these different populations to understand them. But thank you, it's a very excellent point. So I believe we're going to be coming to a close, Noreen. Are we in our time frame?
Yes, we are over, and we just want to thank everyone for attending and thank our speakers. And as people say, I wish you could hear the applause, but that's not possible on Zoom. So thank you for this wonderful a different way of looking at healthcare disparities through historical context. So everyone have a good day, and bye now.